Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are Two Peaks in a Pod. Well, hi, everybody. Welcome back. We are getting very close to the holidays. Are you all ready? Is your Christmas shopping done?
Not really.
I knew it wasn't. You work all the time. You don't have time to shop.
I've done fairly well with my family, my extended family.
Yeah.
But Steven, not ready. I'm not shop for my husband.
Yes.
It's so really hard. And he ruins every surprise. I did order him something, a printer. He already knows. He's like, what's that package on the front porch? And he brought in a printer. He's like, great gift.
I know. I'm like, this is an unusual gift, a printer. Okay, gotcha.
It's something he needs so that sometimes he can print out his patient list at home. I'm like,
maybe he'll get you a vacuum or something for Christmas.
I know, so it's probably fine that he saw it.
Okay, well, when you're old and married like me, maybe you guys will do what we do, which is we're like, how about we not buy each other gifts?
We say that. I'm always like, we really shouldn't. Or I'm like, I really want a new couch.
Yeah.
things like this that we're just going to buy for ourselves.
Yeah.
But he always is really thoughtful. And I'm,
yes. Yeah. I just told my husband, I'm like, your gift to me is that I don't have to buy you a gift because we're too busy.
Yeah, that was really good.
Okay, good. Well, we're kind of on a roll here with Paris Hilton. I usually like to mix it up a little bit, but she's just giving me a lot of content here with her show, Paris in Love. And so what I wanted to talk about today is I was watching a recent episode where she was giving herself an injection. And I noticed when she was giving the injection that it really seemed to cause her a lot of pain. And that kind of surprised me because a lot of the injections that we give, I mean, I'm not saying they're fun, but they're not that painful, but there is one that's kind of famous for causing a little bit more burning. Mm-hmm. And so I was wondering if it was that medication called Menopur. I showed you the video earlier. What do you think? Do you think it was Menopur that she was?
It's my best guess. Okay. Context clues, I think it's Menopur. Although for me, I did have another medication that burned a lot when I went through IVF. So
which is the other
one?
Okay. Yep. Ganirelix, Cetrotide, Menopur. I think they're all pretty famous for sometimes causing burning. But one of the nice things for our patients is in most cases, we're not using Ganirelix or Cetrotide anymore. We use a pill instead to replace that medication. But we are still using Menopur, I think, for most of our patients, right? So I thought this would be a good opportunity for us to talk about Menopur because we just got a little bit of distressing news the other day, which is a medication that we use on pretty much all of our IVF patients is going to be on back order.
Yes,
supply shortage.
Yes, it was huge news. And of course, we're doing the exact wrong thing. Everyone's like, order all of your Menopur ahead of time. Get as many orders as possible so that you're the first ones to get filled. I'm like, doesn't that make it worse?
I know. That makes the shortage even worse. People are hoarding Menopur right now, I think, right?
Yeah.
And I think for the first question that came to my head is, why are we having a Menopur shortage? I don't think they really released any information on why they're not going to have any available, but I think common reasons would be, maybe there was a problem at the factory or something. I think it's probably made in China. Do you know where it's made or?
I do not.
Okay. Yeah. I don't think it's made in the US. So we don't really know the reason why, but we have been told to potentially expect a long shortage. And so I figured we'd kind of talk to all of you guys about it because I think everybody in the US is going to be affected by it. And so I thought we could talk about why this is important. What does Menopur even do anyways? And can you still have IVF if you don't have your Menopur medication that we would typically use? Okay. So one of the interesting things that I was going to bring up is the place you were at before, I think, didn't use Menopur, right?
We used it.
Oh, okay.
But we also used another medication, equally, if not more, to provide the function that Menopur does for IVF.
Okay.
So, we can jump into it. So essentially, there's two basic medications that we give during an IVF stimulation to make your follicles grow. And the components are FSH and LH, essentially. And, not exactly that makeup, but those two ingredients are what we use to make your follicles grow, which are the houses for the eggs. And the way that we can provide the FSH and LH is just with different medications and different kind of combinations of those medications. Menopur is a medication that has both components, FSH and LH. And you can get that LH component from another medication called low-dose HCG. And so we would actually, a lot of our stims, we would use low dose HCG to provide that LH component.
Yes, yes. So I think when the kind of my first thought is when we are not going to have Menopur available, we say, okay, well, I'm glad we still have our other medications available. So oftentimes your doctor may be using Follistim or Gonal F. Those are brand names for FSH medication. So that should still be available, which is great. FSH stimulates those follicles to grow bigger, but most of us like to add the Menopur on because Menopur is the only one that has that LH effect when you compare it to Follistim and Gonal F. And I think it's always cool to bring up just how Menopur is made, right? I think it has such an interesting history because it actually links back to postmenopausal nuns. That was kind of in the beginning.
Mm-hmm.
They would take their urine and then highly purify it so that they could get this mixture of FSH and LH and then use that to stimulate the ovaries. And the reason that a woman in menopause would have such high levels is those are the hormones that come from our pituitary gland to stimulate our ovaries. And whenever we hit menopause, the ovaries are not responding like they should. And so the brain keeps trying to make higher and higher levels of FSH and LH to tell the ovaries to wake up, and they just won't at that point. But because of that, the urine of women through menopause are going to have very high levels of those very valuable hormones. And so I always thought that was kind of a cool background too, which I think we've talked about that before too.
Yes, but like somewhat disgusting sometimes.
Yeah. Okay. Valid.
I know. I mean, I just always think it's bizarre. When I was injecting, I was like, oh, this is a little bit strange.
Yeah. But then and so I guess I want to bring up too why adding some LH is important. And I think what a lot of people don't realize is that FSH stimulates these little cells in your follicles to make estrogen. But in order for our bodies to make estrogen, we have to have a building block to be able to make that estrogen. And surprisingly, in women, that building block is actually androgen, or what a lot of times we would say male hormone. Okay. And so in the follicles, these little cells, you have cells that make estrogen, you have cells that make androgens. And what stimulates those cells that make the androgen building blocks? LH. That's what stimulates it. And so, knowing that, I think it's nice to also talk about why would using compounded low dose HCG, why would this work? Because instead of LH, we're giving something else. Why would that help us? So do you want to talk about that a little bit?
So LH and HCG are both very similar structure of hormones. And so you can imagine if a hormone goes to a receptor, and that's almost like a key going into a lock, LH is a key that can unlock a certain type of door, and that same door can be opened with HCG because they have a very similar chemical structure. And so when it's we really don't need a lot. When it's at these lower doses, it has a very similar effect, or an LH effect, on your cells in your ovaries.
Absolutely. And I will say too, sometimes people have asked really great questions like, why don't we just have just LH by itself that we can give? And I will say in other countries, they have had these options before, but the hard part is LH has a very short half-life. That means it doesn't live in our system very long. And nobody wants to have to take multiple injections all throughout the day. So it is nice when you can use something like HCG, because HCG will bind to that LH receptor, but HCG has a longer half-life. So it will stay in your system longer and therefore can be a very effective alternative to
Great
use
point.
as well. Mm-hmm. Amongst the shortage that we're going to be expecting, instead of using Menopur, we do think it's acceptable and fine to use the low dose HCG instead. And we both used it before, and I didn't really feel like I saw any issues or problems.
I would say I probably used it more prior to coming to Texas. And I really like it. I think patients like it. Probably they like it more than Menopur for exactly the reasons why we just saw Paris Hilton complaining about it.
My patients told me there's not really any burning with it, right?
I don't think so.
Yeah. Okay, great. Which I will say too, in regards to the burning issue, it was interesting because I have tried to report this to the manufacturer, actually several times. And actually, the very first time that I reported it to them, they said, "Really, your patients are saying that? We never hear that."
Oh my gosh.
thought, is it just my patients? Am I telling them to do it wrong or something? I kind of look into it. No.
Yeah.
And when I told one of my patients that, she was like, no, Dr. Reed, go on TikTok
Yeah.
and search Menopur burn, or I think they even call it Metaburn.
Yeah.
And you will see video after video after video of people talking about the Menopur burn. It is a well-known phenomenon. And so then I talked to them again, and I said, look, check social media.
Yeah. Check your facts.
It is happening. Is this a pH problem? Try to get this figured out. And, it just, they haven't really changed anything, unless maybe that's why we're having the shortage. Maybe they're reformulating or something.
That'd be great.
But I give them a hard time. I'm like, Menopur, do you guys hate women? Like, why won't you change this? Surely there's a way to make it, more comfortable for this injection. I know it's possible because when they take their other injections, most of the time they don't really have any issues or problems with that. So. Okay, so in terms of the medication, I've been getting some good patient questions about how it might be different when compared to taking Menopur. And so one of the things, and I think this makes a lot of sense, I loved this question that somebody brought up, is they said, okay, well, Dr. Reed, I know that when it comes time to trigger my follicles for an egg retrieval, you use HCG. So if you're giving me HCG before it's time for my egg retrieval, am I going to ovulate too soon? And so I just wanted you to kind of talk about that a little bit as well.
Yeah. So the dose that we're going to give you to function as LH is really, really low. The dose that we're going to give you for you to trigger and basically start that process of ovulation is much higher. So the way hormones act in our body, when they're circulating at a certain lower level, they can often have completely different functions than when they hit a higher threshold and then are able to achieve something much bigger like ovulation. But interestingly, they have looked at, because one of the big questions is there some sort of ceiling or some sort of limit when you're doing an IVF stimulation that you really shouldn't go above exposing these follicles to LH? And one of the theories is if we give you too much LH or say HCG, can you kind of have this like attenuated or small, premature ovulation, then later not ovulate properly, basically. And so there are a lot of theories out there that are in the literature. So I do think it's a good question as to, could there be some worry about dosing too high during the stimulation and then ultimately hurting yourself later? But in my experience with stimulating with LH and low dose HCG, I've never seen women have enough of it to really affect their surge later.
Yes. And I will say too, I think sometimes it helps to just know that even Menopur, which they market that it's FSH and LH, but if you actually read the fine print, it actually says FSH and LH driven effect. They do, well, I guess I should be careful on how I say it. I suspect that they add a little bit of HCG to their Menopur anyways. I will say, I think on the company level, they officially deny it, but I've seen a study where they looked at all the metabolites in Menopur and they highly suspect that they actually add a little bit of HCG to their formula anyways. So I don't think anybody should feel worried or scared because I think it's already there. And the other thing is too, when I was at UT Southwestern and we did a lot of research there, we would check HCG levels on our patients who were doing IVF, and we would typically see a small amount of HCG in their system while they were taking Menopur. Now, some people could say, oh, that's HCG coming from the pituitary gland, which sometimes that certainly can happen in menopausal women anyways. But again, we kind of suspect that some of the HCG was added into the Menopur. So it probably is not much different than if you were taking regular Menopur anyways. Yeah.
One thing I think we should caution about, because I have seen it happen to a couple patients, is that now, let's say you've done IVF in the past. You were used to using Menopur and you're going to do IVF again. And this time you're going to use low dose HCG. Your trigger shot is also HCG, as Dr. Reed said. Sometimes those are Pregnil, Novaril, even we use Ovidrel sometimes for IVF stimulations. All of those things are HCG. I have seen women accidentally start using their Pregnil or their Novoril, which are HCG, thinking it's their low dose HCG, and that will affect your stimulation because, like I said, it's much higher doses. And so you have to read your labels this time. Make sure you clarify with your doctor, okay, which medication is which, what is my dosage? I have seen a few patients have messed up stims because of that. Very frustrating.
That's such a good point. I'm glad you brought that up. And actually, it kind of made me think of another point too. So, as we told you before, Menopur has FSH and LH driven effect. And so we're saying instead of that LH driven effect, you can do the low dose HCG. But that means we're missing the FSH that the Menopur would have given us. Okay. So routinely, if you're going to be using this as a replacement, then you need to take a higher dose of your FSH, your gonal F or your follistim, so that you can account for that as well.
Yeah. So, for example, you may have been used to one of our high dose protocols is 300 of follistim or gonal F, and then 150 of Menopur, which is 2 vials. So, if we were going to change that out to be low dose HCG, that would be a dose of 450 of follistim or gonal F. So, you're going to think, wow, I'm doing way more medication, but you're really not, because we took away all that FSH that was provided by Menopur. And then your low dose HCG dose, you'll probably be on a higher low dose HCG dose, something like 50. And so that's more of the max dose protocol for someone that's going through medications.
Yeah. And I think that's important to remember too when you're calculating cost difference, because I remember when I first learned about low dose HCG, I thought, oh, it's so much cheaper than Menopur. This is great, But then when you factor in the fact that you have to buy more of the expensive follistim or gonal F, it really kind of is pretty close in cost from what I found. So,
Definitely.
But I'm just thank goodness that there is an alternative that is available that we'll be able to use as well. But I have to say it's frustrating because we are seeing all types of drug shortages. I don't know if you saw some of the local pharmacies are running out of prometrium, which is the common type of progesterone that we're using.
Yes. Well, I've been waiting for endometrium to come back for a while. So endometrium is another progesterone suppository that we use for IVF often, and it's made from the same company that does Menopur. And that one, I still don't think it's back, right?
No, it hasn't been back. Yeah. And actually, then I heard an interesting rumor about growth hormone. There's been growth hormone shortages, which the use of growth hormone very controversial, but it is also on a national shortage. And what I read, the rumor is that if you look at one of the growth hormone pens, it looks very similar to an Ozempic pen. And apparently it's the same company that makes those, right? Well, so Ozempic is a weight loss medication that everybody wants because it's what the celebrities use to lose weight and everything, right? So there is worldwide demand for it. Nobody can keep up with that demand. And so the rumor is that to keep up with the demand, they've been producing less growth hormone pens and instead using their resources and people to make more Ozempic. So, I mean, I hope that's not the case behind all these fertility medication shortages, but definitely a frustrating situation to be in, I think, on the patient side of things, right?
Yeah, certainly.
Yeah. Okay, another question that my patient had that I thought was a really good question. So she brought up to me that we know that towards the end of a retrieval, if somebody is at higher risk of getting hyperstimulation syndrome, that we will often hold the HCG trigger. So we will not give an HCG trigger, and instead we will do a Lupron-only trigger because we know that will give us a dramatically lower chance of that patient getting hyperstimulation after the retrieval. And so she had concerns. Okay, well, you're saying I shouldn't take HCG because I'm at higher risk of stimulation, but now you're going to give me HCG. Good question, right?
It is a good question. Yeah. I mean, I gotta see the logic.
Yes, yeah. So what advice would you give her on that?
So certainly not. I've never seen that happen with anyone using low dose HCG. It's just not at the levels. Basically, the thought is with HCG, and really you can go back to who got the worst hyperstimulation syndrome. It was patients who got pregnant, like a fresh transfer after IVF. And why is that? Because they had HCG levels that were lingering in their system for, until they delivered, right? So it didn't go away. So even in, let's say you get an HCG trigger and you do get hyperstimulation, there's a finite amount of HCG in your system. Eventually it's going to go away and you're going to recover from the hyperstimulation syndrome. When you're using low dose HCG, it is out of your system, not hanging around a long enough time that it's going to trigger a hyperstimulation. It's just not enough there.
Absolutely. Yep. And two, I mean, I think the other thing is I said, look, we'll be monitoring you as we go along too, right? So after you've been on the medication for a certain period of time, we'll check your estrogen level. We'll make sure that your levels aren't getting too high, and we can always adjust as needed. As well.
Yeah. Another kind of phenomenon about LH and FSH that I'm curious about to see if you ever do it. And patients, maybe you've had this happen to you. So when we were really worried about hyperstimulation syndrome, and maybe for some reason you can't use a Lupron trigger, there are certain patients that you can't give a Lupron trigger to, they won't respond, particularly the hypothalamic patients and who don't have any of their endogenous LH to make them surge, right?
Yeah.
And you may try something called coasting or uncoasting. Do you ever coast or uncoast your patients?
I haven't personally done it, but my partner that was at the last practice, I would see him do it on occasion. And it certainly seems like an acceptable way to do it. Coasting just means, you take a break for a couple days from your medication. And a lot of times when your follicles are bigger, they'll just keep growing anyways. Like you don't have to worry about it. They don't typically crash or anything like that. But I think it's just not as common. Do you do a lot of coasting?
So what I think is interesting about using low dose HCG is you have a little bit more ability to what we call uncoast, where you can actually rely on LH to just finish the follicles at the end. So the idea is someone's going to have a lot of follicles around. We're going to recruit as many as we can. Basically at the beginning of the cycle, that's fated. We know how many are going to grow, right? They start growing. We're feeding them fuel. We're feeding them FSH. We're feeding them LH. Well, eventually they get to a point where LH can feed them alone, but smaller follicles really can't be fed with just LH. So the idea is to uncoast, you're taking away FSH and you're just feeding them LH. So you just get those bigger ones that you got to grow to continue, and you choke off all those smaller ones. And so then they don't release as much estrogen and decreases chances of hyperstimulation syndrome and things like that. So you basically finish up the ones that you got, and you don't get a lot of the smaller ones that are coming up, which they say the small and intermediate sized follicles are often what we worry about for hyperstimulation syndrome. So I did see that a lot. And I think it's interesting here, everyone uses Menopur. Everyone, right? So it would be hard to uncoast, right? Because it has FSH, your only source of LH is mixed with FSH. So certainly really haven't seen that where I am now, but saw that more often, that people would really flip ratios and things like that. So it just gives you a lot more flexibility. I'm used to having like a lot of different tools. I like to do a lot of different protocols and things like that. It's just kind of fun to, now we're going to have this other medication that we can do a lot more for patients with. So.
Right. So, I mean, I think it's it doesn't seem logical, but I'm actually excited about the shortage, because I'm like, you know what? I think it's going to give us a chance to just use an alternative that actually patients might like better, and docs might like better as well. And we'll have to see how long the shortage lasts for that. But I will say too, it was interesting. One of my patients works with horses and fertility. And she was just telling me that really, I mean, in a lot of cases, they're using the exact same medications on horses for IVF, but they're so much cheaper.
Does she want to use horse medicine?
I mean, she didn't say that, but I was talking to one of my OBGYN friends yesterday, and she was like, I would definitely use horse medicine. And I'm like, no, I would not recommend that. Because you just don't know the potency and the safety and all the rest of it. But I would say it just speaks to a bigger issue of why are our medications so expensive here in the US? If you compare to other countries, they're so much cheaper. If you compare to animals, they're so much cheaper.
So funny. Well, I don't know anything about horses, but I do know dogs, because I love dogs, as you know. And my experience with my dog medications is, my vet tells me, and correct me if there's a vet listening, but that dogs require more medication than humans do, because they metabolize it more quickly for the most part. So I've also heard of people
Yeah.
using like pain medicines and things like that from their dogs because they're very strong. So that would be the same concept. But I would worry that like the IVF medications are really strong if it's for a horse.
No, I know. Well, but that kind of spoke to cost too, because they were like, imagine the doses we have to use on a horse. Like, but yeah, the cost is just so much cheaper. So it's not a big deal for a horse to be on, I guess, Menopur, Follistim, and all the rest of it. So I love just learning about all this. IVF? For breeding purposes, I guess with horses, there's good horses, like race horses,
and they're
certain
having
types of
problems
horses.
Getting pregnant, or they want like
I think they want like a really good, well-bred horse, from what I understand.
Interesting.
Yeah,
very interesting.
Yeah. Our lab director knows a lot about it too. She also does, I think, horse IVF. So, I know. I've been fascinated by it because I'm like, so you do an egg retrieval. A lot about cows. They do an egg retrieval, just like we would do an egg retrieval. But it does require like two people, because like one has the ultrasound probing and the other one's doing the needle and everything. So I'm fascinated by all of this. So yeah.
Very interesting.
Okay, good. Well, should we wrap it up for the week?
Let's do it.
Okay, good. All right. Well, thank you guys. We will see y'all for the next one.
All right,
Bye.
happy holidays.